Welcome back to Revenue RX, the podcast at the intersection of pharmacy and finance. I'm your host, Lubna Mazen, and today we're talking about the language of reimbursement. One of the biggest barriers to understanding healthcare finance isn't the regulation. It isn't the contracts. It isn't even the coding. It's the vocabulary. ASP, WAC, AWP, HCPCS, DRG, APC, CARC, RARC. To someone new to healthcare reimbursement, it sounds like alphabet soup. But every one of those terms tells us a story about how we get paid in healthcare. And if you want to understand pharmacy revenue cycle, you need to understand the language behind the payment. In today's episode, we're building your reimbursement dictionary. Every reimbursement story begins with the charge. A billed charge is the amount your organization submits on a claim. Think of it as the sticker price. If a hospital administers a medication and bills $10,000, that is the billed charge. Now, here's an important part. Almost nobody gets paid their billed charged amount. It's based off of what the payer agrees to pay. Sometimes that's a percent of charge, sometimes it's a fee schedule, and sometimes it's a specific price. Which brings us to our next term, allowed amount. The allowed amount is the amount recognized by the payer for reimbursement. Let's say your organization billed $10,000. The payer contract only allows for $6,000. The allowed amount is $6,000. Most clinicians focus on the charging due to limited visibility into the reimbursement. However, revenue cycle professionals focus on the allowed amount because that's where the payment actually begins. So what happens to the other $4,000? That is called the contractual adjustment. The payer isn't denying the charge. They are simply stating that for the services rendered, we have agreed upon the allowed amount. So billed charges was $10,000, allowed amount was $6,000, and the contractual adjustment was the difference of $4,000. Now let's talk about two numbers finance teams care about. Gross revenue, which is the total value of all the charges generated, and net revenue. That is what remains after the contractual adjustments. So if you want to understand the financial health of an organization, net revenue is usually the more meaningful number. Gross revenue reflects what you billed. Net revenue reflects what you will likely collect. Next, let's define the term behind this entire podcast, revenue cycle. The revenue cycle is a process of getting paid for the care you provided. It starts before the patient arrives and it doesn't end until payment is posted and reconciled. It includes everything from benefits verification, prior authorization, documentation, charge capture, coding, billing, denials, appeals, and payment posting. All of these aspects are part of the revenue cycle. Revenue cycle isn't just one department, it is an ecosystem of teams working together. Now let's tackle one of the most misunderstood distinctions in healthcare reimbursement: denials versus rejections. A rejection occurs before the claim is adjudicated. The payer never processed the claim. Common reasons for a rejection include invalid member information, missing fields, formatting issues, or incorrect claim submission. Think of a rejection as the claim never made it through the front door. A denial occurs after adjudication. The payer reviewed the claim and decided not to pay all or part of the encounter. Examples for denials include missing prior authorization, medical necessity, coverage exclusions, and timely filing violations. A rejection is usually a data problem, while a denial is usually a reimbursement problem. Once a claim doesn't pay correctly, the next question becomes, why? That's where CARCs and RARCs come in. CARCs stand for Claim Adjustment Reason Codes, or simply referred to as reason codes. RARCs stand for Remittance Advice Remark Codes, also referred to as remark codes. Think of CARCs as the headline and think of RARCs as the supporting details. The best denials management teams become fluent in both because understanding why a claim paid incorrectly is the first step towards resolving it. The remittance advice, often called an RA or an ERA, is the payer's explanation of the payment. It tells you what was paid, what wasn't paid, what was adjusted, and why the payment was what it was. If claims are where reimbursement starts, remittance advice are where reimbursement becomes reality. Revenue codes identify where services originated within the hospital. Examples of common revenue codes in the pharmacy world are revenue code 250 for general pharmacy line items and revenue code 636, drugs requiring detailed coding. In future episodes, we'll go more into revenue codes. Modifiers provide additional information about a service. The HCPCS code tells the payer what happened. The modifier explains the circumstances. Pharmacy teams commonly encounter JW, which is for drug waste, JZ for zero drug waste, JA for drugs administered IV, and JB for drugs administered sub-Q or IM. Modifiers can completely change reimbursement. In future episodes, we'll also take a deep dive into modifiers. Next term is HCPCS. You can pronounce HCPCS as HCPC or HCPCS. It stands for Healthcare Common Procedure Coding System. And before we go any further, I need to address one of my biggest pet peeves. People love to call every drug code a J code. However, we have J codes, Q codes, C codes, miscellaneous codes, temporary codes, pass-through codes, and the list goes on and on. Calling every drug code a J code is like calling every flower a rose. Everyone knows what you mean, but it's not technically correct. And in reimbursement, technical correctness matters. Next, we have CPT codes. CPT stands for Current Procedural Terminology. These codes typically describe a service or procedure. For pharmacy teams, administration billing often lives here. For example, 96365 for initial hour of an infusion or 96372 for an injection. The HCPCS code identifies the drug. The CPT code identifies the service. Together, they tell the reimbursement story. NDC stands for National Drug Code. Think of this as a drug's fingerprint. The NDC identifies the manufacturer, the product, and the package size. The next few terms are related to drug pricing, and we do have an entire episode focused on this, so I will simply go over the acronyms. ASP, average sales price. WAC, wholesale acquisition cost. AWP, average wholesale price. GPO, group purchasing organization. 340B, which is a federal drug pricing program that allows eligible covered entities to purchase medications at reduced prices. Next, let's move on to Medicare payment methodologies. APC stands for the Ambulatory Payment Classification. This is where outpatient hospital services are reimbursed under Medicare. For inpatient care, we move into DRG, diagnosis-related groups. Under a DRG methodology, hospitals receive a fixed payment based on diagnosis and complexity, which means operational efficiency matters in DRG payment methodologies. MAC. MAC can stand for the Medicare Administrative Contractor or the maximum allowable cost. The Medicare Administrative Contractor, these are organizations that process Medicare claims in specific geographic regions, while the maximum allowable cost is the upper limit a health insurance plan or pharmacy benefits manager, PBM, will pay for generic or multi-source products. And CD is the National Coverage Determination. This is a nationwide Medicare coverage policy. LCD is Local Coverage Determination. This is a regional Medicare coverage policy. LCA, Local Coverage Article, provides additional guidance supporting billing and coverage decisions. MUE, medically unlikely edits. MUEs are maximum units of service that a provider can report for a single CPT or HCPCS code for a patient on a single date of service. Healthcare reimbursement has a language of its own. ASP, APC, AWP, DRG, NDC, NCD. At the beginning of this episode, those may have sounded like random acronyms. Hopefully now they tell a story. Often in pharmacy, we serve as translators between clinical care, finance, managed care, coding, and billing. Hopefully today's episode helped you add a few new terms to your dictionary. Thank you for joining me for another episode of Revenue RX. Healing patients is the mission, protecting the margin is the strategy. This is Revenue RX. Disclaimer: this podcast is intended for informational and educational purposes only. The views expressed are my own and do not represent those of my employer or any affiliated organization. This content does not constitute as legal, financial, or reimbursement advice. As always, consult your internal compliance, legal, and revenue cycle experts when making operational or strategic decisions.